and actually for supporting this program. So this is our first workshop series, how to ask the right questions in clinical and translational research. So just some public service announcements. So tomorrow, we're having the Department of Medicine's second annual research symposium. This is going to be over at the Woodlands Plaza, right over in the hotel. The keynote is Dr. Joan Bailey Wilson from the National Human Genome Research Institute, and her talk will be The Long Road to Understanding Genetic Risk in Lung Cancer. So that will be at 4 p.m. over in the Woodlands Center. And then from 5 to 6:30, we're going to have a poster session. So we highly encourage all of you to attend this. It's a really great opportunity to hear about all the fantastic research going on in the Department of Medicine. And next announcement, we're starting a new Translational Medicine Journal Club. So this is going to roll out in November, and we'll send updates on that. So please keep an eye out for that. It's open to graduate students, undergraduates, medical students, pharmacy students. There'll be roughly 1 hour meetings. And David, did we set, I think we were thinking Wednesdays, but keep an eye out for that. We'll send out some reminders as we get that set up.
Ben French, if Ben, you have to wave your hand. So Ben will be one of the students in charge of helping to organize that.
You're funding it for Fridays.
Oh, all right. Maybe Friday.
Fridays, just for you.
Just, yeah.
Okay. All right, I'm going to pass things over to Dr. Kennedy for introductions.
All right. You don't want to hear me talk, but I just want to just highlight, we have 3 fantastic speakers today. Dr. Lance Dorkin, who's the chair of medicine and has really been just uber supportive of this program and providing research experiences. And you'll see he's got a great passion for, for mentoring and involving students in research. Dr. Bashar Kahali, who's the chief of our division of rheumatology, and he'll be speaking as well. We've worked with him for a very long time. Another fantastic translational researcher in the Department of Medicine. And then Dr. Ragib Asali, who is also currently chief of pulmonary critical care medicine, also in charge of our residency program, internal medicine residency program. So the format for today, we'll have each of the speakers, which is a workshop. They'll give a few comments, have a few slides, and then we'll open up for sort of panel discussion at the end. So again, I don't want to take the time because you're here to hear them. So I will pass things off to Dr. I don't know if you prefer this or we can mic you up this way too, either way. This is this. And then if you just advance here. Okay. So, all right.
That's my disclosure slide. So anyway, thanks for coming. So this is a big topic. It's actually one of the most common questions that people ask me, how do I pick out a good question for a research study? And, honestly, I've always felt that there are so many questions and so few answers that it's really relatively easy. But I'm just going to talk about a couple of ideas, and then we can have more of a discussion. So what are good questions for research? Pick a problem that's relatively common. So I'm not sure what level you're all at in medical school. When you get on to the wards and start taking care of patients, what you'll see is we do a lot, but we don't have good reasons for a lot of the things that we do. We try to practice evidence-based medicine, but oftentimes the evidence isn't there. Every time you get into a situation where you have a patient that has a problem and the correct course of action isn't clear, that's an opportunity to learn something. And those problems are relatively common. Another good question is a problem where there are different treatment options. So some physicians might treat a patient this way, another physician might treat a patient a different way. If there's 2 options, then they could be compared. The best treatment is unknown. There are risks associated with either approach. Sometimes there are questions that are worth asking, not so much because we're going to impact hard endpoints for clinical trials like mortality, let's say. But just because one option versus another might be associated with a better quality of life or might be more cost effective. And those are also legitimate questions. Whenever we do research, we want to make sure that when we study these questions that we're aware of other things that impact on them, like social determinants of health, and also that when we enroll patients, it's representative of the population that we're treating. And then the last thing that I like to try to find are questions that are important, whether the trial is positive or negative. And you know, this is just a study that was published a few years ago, just comparing the outcome of studies in terms of whether they were published or not, depending on if they were positive or negative. So, I mean, here's a good example, right? I mean, this is a pretty simple-minded question, yet, you know, somebody just went back and looked at a bunch of studies and saw whether they were published or not, and it ends up as a publication. But anyway, you can see that studies are, not surprisingly, studies are more likely to be published if they're positive than if they're negative. But if you ask a question where, regardless of whether the outcome is positive or negative, it's going to have an impact on therapeutics, like sometimes not doing a procedure, if it's useless, could have a huge impact. There are a lot of examples of that in medicine. About 15 years ago, there was a procedure that became commonplace for a short period of time in patients that had ischemic heart disease that involved the small blood vessels. And so it wasn't amenable to angioplasty and stenting. And a case series was published where somebody took a laser and drilled a lot of holes in the endocardium. And that was supposed to promote ingrowth of blood vessels into the heart. And when they published the result of this case series of 100 patients or something that somebody had done, it had a dramatic impact in the case series on the incidence of angina. So after this procedure, people had much less chest pain. And then there was another observational study that showed the same thing. Just a series of patients in whom this was done without a control group. And in the wake of those two studies, cardiologists around the world started doing this procedure. And then after a couple of years, it was actually subjected to a randomized controlled clinical trial and found to be of absolutely no benefit, and all those procedures stopped. So that's a good example of a clinical trial that's negative, right? You're testing a therapy, it has no impact, but it has a huge impact on clinical practice because you stop people from doing something that has no value. So these are just some general thoughts about how to do this. So think about how you're treating your patients, what you're doing, and why. Is there really good evidence for the treatments that you're providing? A lot of times there are, sometimes there is. If you look at how to treat hypertension, you know, there's hundreds of studies over 30 years. You look at some other diseases, very little evidence. Whenever I come up with a question, the first thing I do is go to the literature and look it up, do a PubMed search, and pull out everything you can find that's been written about it. You may find that the study's already been done, or if it hasn't, you'll find that there actually isn't a lot of information. If there isn't a lot of information, recent publications about it, that's a good question. But it's always important to go to the literature. The other thing that I like to do is, you know, oftentimes when we're taking care of patients or when we're working in an institution, we come up with an idea, quality improvement project, anything you might think of, we're going to change something, change the way we do things. We just implemented a whole new electronic medical record. Is that going to have a positive impact on patient outcomes and patient care, physician well-being, whatever, or a negative impact? So anytime you're changing anything, anytime you're involved in anything that's changing, there's an opportunity, even if it's not really being designed as a study. There's an opportunity to collect data before and after the change and see what was the impact. Did it help? Did it hurt? Did it have no effect? And oftentimes that's useful information. So I try to think about it, try never to change anything without having some way of assessing, what the impact of that is, and collecting a little data. And then once you collect that data, there's an opportunity to present or publish it. So that was about all I wanted to say. So turn it over to the next person.
All right, so again, we'll have at the end, we'll have answer from the. You have slides, I wanted, all right, so next will be Dr. Bashar Kahali. Oh, sure. Yeah.
You just,
Okay.
right there.
Well, thank you very much. It's a pleasure to be here. And I would like to approach this from a clinician point of view. The asking a question is really extremely important in life. Ask a meaningful question, nowhere more than in research. You have to know how to ask a question. This is a famous quote from Voltaire, a French author, a humanist. Judge a man by his questions rather than his answers. So the question is extremely important, and the right question would lead you to getting to the right answer. And one have to have a curious mind. The power of curious mind is extremely essential for understanding coming up with the important and significant question. That is typified by what Albert Einstein had done. He asked questions all the time, and he even challenged the existing dogma, and he questioned even the laws of physics. And by doing so, he ended up with discoveries that changed the human life centuries to come. So asking a good question usually follow publication and result of studies. So most of the publication in medicine, medical research, is primarily focused on study of intervention and outcome and effect of new medication and or rediscovery of old medication on a given clinical situation. Yet it's very frequently little attention is focused on the quality of the question and the depth and the specificity of those questions. So where do you get to find questions? What the sources for a good question for you to follow? So there are many sources that we are subjected to. Patients always ask questions. For instance, I put here, how can I return to my work after having myocardial infarction and undergoing rehabilitation? So those kind of inquisitive questions may lead you to begin to start to think in terms of the problem and how do you want to solve it. Patient with the arthritis is how long this pain is going to last. Sometimes the question may come from your own clinical research experience. I'm a rheumatologist, and I see patients who have arthritis. So one of the questions that always come, what is the best way to help prevent joint damage? Because arthritis is usually a debilitating, disabling condition because of the damage to the bone and joint. And that question always that we ask, what would be the best approach to prevent the damage to the joint? Sometimes a colleague could trigger a question in your mind, like asking, so why did you do a CT scan instead of MRI? That will make you stop and think, what's the rationale? When should I do this? And what conditions should be appropriate to do a CT scan versus MRI? So the questions are many, and the questions are flying all the time. And in order to be able to focus more on a researchable question, there have been suggestions of using certain filters to filter out those questions in your mind and help you to focus on a focused, answerable, and researchable question. So one of the filters that have always been used is importance. So when you review a proposal, a grant for submitted by somebody, you have to think in terms of that question, is that important? How important it is? Is it a trivial question, maybe scientifically attractive, but has very little importance? Is it relevant to the current practice and to current issues and problems? And one of the most really important filter is to understand whether to test the possibility that this question is answerable. Because many times you have a question in your mind about a certain subject and topic that may be not answerable. So this filter will help you decide whether the question that you have is filterable, is it answerable, is it researchable, and by looking at the tools that are available to answer a question. Level of interest in the question in the general population is extremely important among your colleagues. And the likelihood that you are able to see that question in your practice, in your daily living, you don't want to try to answer a question about something that you don't see routinely or frequently. So many researchers start their research career enthusiastic about answering questions, solving problems, and they think that they undergo a quest of trying to solve all the problems in the world. That is very common in the beginning of research practice, and that leads you nowhere because this is not an answerable question when you start thinking in terms of very large problem. I'm going to cure cancer. How can I cure cancer? That would not work because of the enormous difficulty in trying to answer that question. So the answerable questions are the questions that could be focused, divided into certain small topics that are answerable, that you could answer it. And frequently for that, you would have to see and meet with your supervisor, with the professors, or the head of the team that you work. So once you decide that you have a good question, maybe answerable, it's important, it's relevant, there's a lot of interest in that, that's what will begin the process of looking into literature. This is one of the most tedious and most time-consuming part of trying to come up with a research project. And then you have to look deep in the literature, look at multiple databases, and try to find out if this question that you have in your mind have been certain previous publication or multiple publication, or it's still unknown. So let me give you a small example here. Years ago, I had a back pain, veterinary medicine, doing physical medicine, therapy and whatnot. It was pretty annoying back pain. My wife practiced yoga, so I took three classes of yoga, and I was absolutely stunned by how wonderful some of those stretching exercises in yoga for low back pain. And I started to think maybe we should do more in yoga as a way to treat chronic non-specific low back pain, which is a huge problem. 80% of the population have back pain at one time or another. 2 to 5% will end up long-standing low back pain, and a lot of resources, expensive to take care of, and limit ability to be fully employed and productive. So, first of all, we looked at whether there is any data to suggest that yoga is helpful for back pain, and indeed, there are multiple yes, yoga is very helpful. And we kind of got excited and we were talking about maybe starting a study comparing yoga to physical therapy. Physical therapy is one of those mandated treatment approach and guideline. If you have back pain, you should go to physical therapy. And patients really don't like doing that. It's time consuming, it's expensive, insurance don't like it. So how about if we compare yoga to physical therapy? So we went in and looked into the literature, and here comes a study, controlled, very well controlled study that compared physical therapy to yoga for treatment of chronic non-specific low back pain. And the answer to the study, or that question, was that yoga is not inferior to physical therapy. They both, the yoga arm and the physical therapy arm, reach their primary and secondary endpoint, and there was no difference in outcome. Even a year later, they was both improved, and the only difference was that people who were in the yoga kept their follow-up visit a lot more than the ones with physical therapy. So here that question was answered, but that answer made us think in terms of how about other modality that you could treat that are used for treatment of gout. I mean, treatment for low back pain, like acupuncture, like chiropractor. Chiropractor's treatment of low back pain is popular, expensive, have not been subjected to really good controlled trial. So how about maybe comparing yoga with possibly to chiropractor treatment or other modality of treatment? So that exercise led us to asking more and more questions and looking at more and more modality and what to do with this finding that maybe a yoga may be helpful for low back pain and have to be compared and proven in a good control trial with other ways of treating back pain. This is another issue that had been debated in the literature, and that is factor uric acid in gout on cardiovascular events, coronary heart disease, stroke, myocardial infarction. So there are some studies that show that yes, lowering serum uric acid in gout will improve the outcome of the cardiovascular outcome, reduce the incidence of myocardial infarction in the lung. So in a study that was a controlled, very good controlled trial that looked at the effect of using allopurinol, which is a xanthine oxidase inhibitor that lowers serum uric acid in patients who have diabetes and gout. And studied the impact of that on prevention of cardiovascular event. And there was very significant prevention and less incidence cardiovascular disease outcome in patients who were treated with allopurinol on a background of diabetes and gout. Then this became a very popular idea that maybe allopurinol use could prevent cardiovascular disease. And practitioners start to use allopurinol in patients who do not have necessarily gout, had risk for cardiovascular disease, or already have cardiovascular disease. So that triggered the question, is that really true? Could you use xanthine oxidase inhibitor to prevent cardiovascular disease in general? And that led to this study that is called the Old Heart Study that looked at effect of allopurinol patients who do not have gout, who had cardiovascular at risk for having cardiovascular event, and then enroll them in two arms, one with allopurinol plus current accepted treatment versus accepted treatment without allopurinol. And they increased the dose of allopurinol to 600 milligram a day. And the rationale for that was that they want to get the lowest possible uric acid impact on cardiovascular event. The average dose in the United States for treatment of gout is 300 milligrams. So they decided to use twice as much to get rid of uric acid in the circulation and see whether that would have a good impact on cardiovascular event. And the result was negative. Both the allopurinol and the control did have similar incidence of coronary heart disease and stroke, suggested that allopurinol does not lower the incidence of coronary heart disease and stroke in patients who do not have gout. And this result were published just recently, last month in August. And already this study raised multiple questions, including why should we use 600 milligram? We should test maybe 300 milligram. And they're already planning on that, starting a new study using a smaller dose or targeted treatment to a level of uric acid that is not too low, because it turned out that uric acid level, if it is very low, it's not good. If it's high, it's not very good. And you gotta come to me. So here again, a study, negative study, is leading to beginning of multiple studies trying to look at variation on the theme and trying to look at the exact answer to this issue. Finally, I would like to mention briefly a fascinating observation that the treatment and trials that were done in the early 90s, looking at inhibition of tumor necrosis factor in patients who have congestive heart failure. So the background to that is patients who have congestive heart failure, very high level of TNF circulating tumor necrosis factor alpha in the circulation and in the myocardium, high expression level of TNF. And they also have high level of circulating TNF receptor. And that the animal model suggested that TNF is bad for the heart. It is negative inotropic, so that it does that weaken the cardiac stroke and will increase the weakness of the heart muscle. It also induces hypertrophy of the muscle and also causes apoptosis in myocardial cells. So the rationale here is that if we block tumor necrosis factor, then that should be very good for congestive heart failure. And indeed, they have animal model of congestive heart failure that were treated with blocker of TNF, and the animal did better. So here you have a question that has been very well researched, extremely strong background information and rationale. So they went in and did a multiple randomized control trial, international trial, using tumor necrosis factor receptor antagonist, that is a tyrosine receptor and also monoclonal antibodies to tumor necrosis factor receptors. And both arms, both those modalities, surprisingly gave an unexpected result, and that was that the patient with congestive failure who received tumor necrosis factor inhibition deteriorated, and their congestive heart failure got worse, and there was very higher level of mortality and readmission to the hospital. So that was a huge failure. Some pharmaceuticals did not recover from that until now. And that led to actually the pharmaceutical that owned the Tyrosine sold their right to a trynocept to a small firm in Seattle called Immunex, and that small firm in Seattle introduced a trynocept for treatment of rheumatoid arthritis. And the rest is really history, because to turn out that this is extremely important and effective for treatment of rheumatoid, and this has been one of the most successful drug therapy in the recent years. But this is negative study and didn't make any sense. I mean, all the background information really suggested that this treatment should work. So why didn't it work? And that led to, again, a negative study leading to many questions and more research and trying to understand. And it turned out that tumor necrosis factor have two receptors, two species of receptor 1 and 2. Receptor 1 is the one that mediates the harmful effects. Well, there is a receptor 2 that is a protective of the myocardium. So the idea that tumor necrosis factor itself could be protective, be injurious to the heart, is a new idea. And currently there are trials to try to come up with a higher selective tumor necrosis factor receptor 1 inhibitor. So you could inhibit the one that leads to pathologic event in the heart and maintain that tumor necrosis factor receptor 2 that mediate a beneficial effect. So anyway, this is a negative, terribly negative study that pharmaceuticals lost millions and billions of dollars. Yet I think the end result may end up being very favorable in terms of finding a new discovery and finding a new ways to harness the protective effect of tumor necrosis factor. So I'd like to close here by this quote by Thornton Vipland, who was an economist and philosopher, who said that the outcome of any serious research can only be to make two questions out of one question. And I believe this is really the whole secret and and driving force for progress that we see in medicine. You have a question, you try to answer that question, and that would lead to generation of multiple other questions after you, whether it's a positive or negative study, and many questions will arise. And the only way you will be able to get into that is to read the literature very carefully and try to use your inquisitive mind and try to come up with a question about why the study was positive or why that study is negative. I'd like to stop here and thank you for your attention.
Dr. Collins. All right, we'll go.
Did not prepare slides. But what I would like to do is to share with you my own experience. I've been here for 25 years, right? I was, we call fellows residents. So I was a resident in pulmonary critical care. I'll give you some examples of my interactions and what I would like to share with you as advices, okay? And then I'll say my experience. First of all, I think before you proceed with any endeavor in translational research, you have to ask the question, are we adding anything to the existing literature? That's important. The other thing is, in my mind, the first step in having a successful translational researcher is to have all the tools to critique the literature. So you have to have all the tools, the right tools to critique the literature. That's the other thing. And of course, the ability afterwards to build up knowledge, right? So you have to have two things. Ability to critique the literature and then having good base in medical knowledge. These two things are very important. Now, I think this is unique among many people, but some people are more critical thinkers than others. This is, but by the way, critical thinking can be enhanced. And we do this with our residents. So if you're a good critical thinker and you persevere of what you're doing, in addition, and you have to have a good social skills, by the way, as a team member, you'll be interacting with PhD scientists, you'll be interacting with statisticians, you'll be interacting with students, other levels of research. If you don't have those skills, then your translational research will not be successful, okay? So I'll tell you now my experience, why I reached all these conclusions. My experience goes back to the 90s. Maybe I'm going to quote Dr. Kahali. His lab. I was a pulmonary critical care resident, right? And I had two patients who died because of mysterious death, right? They died in shock. We don't know what happened to them, honestly. But because of that, I kept their serum, their blood. I frozen it and kept it in that. Then I heard that Dr. Kahali's lab is doing some growing endothelial cells. Now, when I searched these two patients, I realized that these patients have something called idiopathic capillary leak syndrome. They leak out fluids for some reason, and they develop shock. Capillary leak relates to the endothelial cells. Hence, I asked Dr. Kahali, what does he think? So he said, let's grow some, I have endothelial cells already, and let's take the sera and expose the sera to the cultures in the endothelial cells. And what happened that we found a significant amount of endothelial cell apoptosis. Apoptosis, programmed cell death, shrinkage. They shrink the cells. So these endothelial cells types, when they shrink, they create interendothelial space. We proposed that. And I was really proud to win an award it's a national award for this, of course, with the assistance of Dr. Kahali, Alfred Sofer Research Award for describing the mechanism in idiopathic systemic capillary is rare. Now that's not the end of the story. That brought my interest in capillary cells and all these things. So I was rounding with Dr. Shapiro, previous dean here, the nephrologist, and there was a fellow, and we had a patient who was almost dying with end-stage renal disease, and he was on dialysis. So we were discussing the case. We're giving him a lot of fluids, everything goes out into the outside the intravascular space. So we said, Dr. Shapiro said, I wish we have something to give to this patient and stays in the blood vessels. Albumin, we know albumin leaks out. It's 68,000 Dalton. If the leak is large, it leaks out. It can be counterproductive. Then what I did, and this comes to perseverance, right? I called the chemistry here. This is what the other things which I think to have a successful translational project, you have to, get other people. So I asked the question, anybody who's interested in albumin? So they told me, yeah, there is a scientist called Dignam, he's retired now, who has interest. So I called him and we met with him and I asked him, I gave him what's the concern? I told him, can we make the albumin bigger? He said, I'll get back to you the next day. So he gets back, he said, of course, yeah, we can. By attaching something called polyethylene glycol, hydrophilic material, which increases the hydrophilic radius. And basically, it increases the size 16 times of the albumin physiologically. So we tested it in rats. Anyway, to make the story short, so the elements which went into this translational experience was, number one, the idea, critical thinking, right? Number two, the perseverance, you call and get. Number three, you look into the literature, see if there is any large albumin, pegylated albumin there, okay? And number four, and this is, I think, the most important thing, is to gather and build up a team, right? A team. So social skills are key to have a successful translational research project, okay? I came across a paper, I sent it to David, I think before I came here. It would be nice to share with the students. It's from NYU, and it says teaching translational research to medical students. NYU has a nice program. I don't know if of really enhancing the training for medical students. Basically, what they say, they want to create a national translational workforce. And the source would be medical students and others, of course. So they have a program, extra year, I think, and they have a curriculum. And as I said, from that, which I think it's accurate, the first step is you need to be able to critique the literature. So you need the foundation when you read an article to say, this is relevant, this is not relevant, especially during these days with the explosion of the open access journals and so forth. So that's the first thing. Following that, of course, medical knowledge comes. Now, I don't expect a recent graduate to have the medical knowledge. I'll give you one example from yesterday. Yesterday, I had a patient who's tiny, small, very small, had lung cancer, heavy smoker, 2-pack a year. Something came to my mind. I know that the lung size depends on the height and the sex women have. So when we say 40-pack a year for this guy, but he's tiny, his lung probably is half the other. So the guideline doesn't address this, for example. So your question is, you need to look at the guideline and say, should they correct the exposure to tobacco? We call it pack a year. How many packs for how many years? Depending on the size of the lung. So the small lung with 20 pack probably is like being exposed to 40 pack, right? That a lot of these now, this stems from experience and knowledge and so forth. But most importantly is the critical thinking. To ask always why. Okay? And the foundation for that is good basis in critiquing the literature. And you have to know that you have to have the perseverance and the social skills to manage and interact with a team with different skills. I think this is what, yeah, thank you.
Thank you. So I'm going to invite the speakers just to come down, and then we have a couple of questions that have come in from people sent ahead of time, but we also want to give you an opportunity to, if you have any questions, to ask them. And we'll just put some chairs up here and we'll That's the microphone. So first of all, any questions from the audience? Jay, go ahead, and I'm gonna give you the microphone so that you can online can hear.
So, my question is, like, if you direct to any of you, but like, you guys talked about like, how like specific questions are like the main thing in the clinical and like translational research, like getting down to a specific question, but I still don't get like, so let's say you had a large section, what would you like do to make that one specific? Like, you know, like get it down to a question that you couldn't do.
To be honest with you, you have to be specific. And in order to be specific, you have to have the criteria. I mean, you have to have the elements I just mentioned there. You know, you can always ask. You have to go down specifics too, because this is the only way to go. You can add an existing.
Yeah, you know, when you try to take a question and turn it into a practical clinical, there's all kinds of pragmatic things that start to crop up. But the colleague was talking about that as a feasible. So, what's your population? Are you going to be able to find the patients? What's your outcome? Is it something that is easy to measure and or difficult? What's the intervention? Is it something that people are going to accept? Is it risky? Is it not? So that's what there are a whole long list of questions like that. You know, what people shouldn't be included, what people should be included. So when you actually go to try to design a clinical, very practical. And a lot of times, what you end up doing in a clinical trial may not be exactly what you would hope to do, just because it's not really practical. So you may come up. So I didn't.
It's really very important question. This level is very hard to see and get the vision of complicated to a practical, solvable, answerable, searchable issue. I can tell you, when I was preparing myself, I don't remember. I was a fellow in University of South Carolina. This bitch was involved in the study of sperm. I don't know. I was involved in that and see salivation suffering from a disease that had no more cause of etiology and treatment or anything. And I was so convinced that I myself am going to solve a problem. Know that this is at this level of your training and knowledge that globally that you could have fusion happen and some of it. This is precisely where mentoring supervisor, if you had a professor, they could the open through this for you could help you cut it down into pieces. Look at what is feasible, what is not feasible. You have to have the experience, the knowledge to know how whether this specific question is feasible, it's researchable, it's going to be done in a quick enough time that you'll see the results yourself.
Yeah, sometimes in the design or clinical trials, the first step is a feasibility study, right? Where you just, so you have a question, you don't even know whether it's the answer. You go and see what could I find in patients. Or could I find in patients? You have a therapy you want to try, is it safe, is it acceptable? So you start small with these things. when you're thinking about a question, if you're interested in the first step is it often it's kind of like the gold standard, and for many things they're complicated, they're expensive, they're hard to do, but there are steps you can do before that. You can just go back and review a series of cases, see how people were treated, and compare outcomes, and people that were versus compare people that were treated to people that weren't treated for some reason. So there are all kinds of ways that you can start to, get some information about a problem without going all the way to the clinical.
A simple example for this, for example, if you go to a website question, first of all, you need to go to the literature and see what's the impact, what's the projected impact you will have. So you have a percent. Based on that percent of the improvement, that you will decide on the number of patients you're going to recruit, enter, so as to have a meaningful statistics. So it's not, having a general questions you start with general, but you have to be specific.
The successful research, the curriculum publication record, you can see that how they were moving step by step, small and over a decade or two, and then a meaningful research and achievement, and the impact of that collective application is huge. So yes, it's difficult to understand how we reach that. And it is really the smaller questions, the one that will be more helpful to you.
Again, I just want to give someone online an opportunity. Amir, Amr, I'm sorry, if you want to unmute and ask your question.
Hi, thanks very much. Good afternoon.
Sure.
So I was wondering, as far as on a day-to-day basis, the tasks that go into performing clinical research, what would someone expect to do if they were to get involved with clinical research? I guess in preparation for, let's say, applying to some projects over the summer, what would be good to get in the habit of doing? And then I was also very interested to know how that compares to translational research as far as what goes into it on a day-to-day basis. Thank you very much.
Sure. All right. So the question is, so two questions, and essentially they're similar. What are the habits of highly effective researchers in terms of clinical research? And is there any difference in those habits in terms of translational research? What should a medical student be doing now to prepare for a career in either clinical or translational research? Let me know if did I get that right? Is it? I'm sorry. Did I capture your question?
Thank you. Yeah, that's exactly it. I appreciate it.
In a nutshell, it's really that clinical research is a completely different phase of research than translational research. Clinical research, in order for you to provide good clinical researchers, you have to be knowledgeable in the clinical disease, asking clinical questions, understanding the tools that clinical research uses to not only come up with a question. One thing I was listening in today's discussion is, okay, you have a question. How would you answer it? What's the study design most suitable for that question? The study design is by itself is really a science. A session is trying to go over which design you should use in order to answer a given question. Now, the translational research, though, the tools is more related to basic science research tools and ability to do the procedures or supervise the procedures that are done in a basic science lab. And I think, yes, I've done both, and I think research we are all tremendous, it is in the boys only. It's very daunting, it's time consuming, and you sit in the lab sometimes for weeks without having to move an inch. While the clinical research is always going on, you're always recommendations, you're always somebody in more routine than this research.
So honestly, at your level, I think the most important thing, if you want to get involved in research, is to identify a mentor, somebody. Really, that's why we're trying to set up this whole program. Make that a little bit easier. So you can go online to the website, you can fill out the form you're interested in, and we will try to connect you with somebody in the department who you can work with. If you have an idea, that's great. If you don't have an idea, you don't have. Because that you may become interested. You know, honestly, I don't think it even really matters what area it's in. My first publication is yesterday. It's about a student period when a few months that I volunteered to work in a lab, and it turned out that somebody was I didn't know gastroenterologist, but I learned a lot about research. So the way we ask questions, the way we analyze data, the way we think about problems, is very important. So honestly, I think the most important thing is to just get involved. You know, if you look at the number of physicians that are actually engaged in research, it's been on a downward decline for decades. When I graduated medical school, people become do science, and a lot of science and research is done by PhDs. PhDs are great. They're very smart. What they lack, what we as physicians bring to the table, is an understanding and a relationship. So we see problems from a slightly different perspective. PhD might do it, doesn't also take care of patients. So I think it's really, really important for physicians to engage in research, because we bring that, everything that I've ever done, whether it was basic science or not, to me, it always had some problem or something that was affecting patients that I was thinking. Those were always the questions that were answered. So what I would encourage you to do is just get involved and then continue to be involved even after you finish medical school, after you finish residency. Just continue to ask questions. It's really one of our obligations as professionals, right? It's not only to care for patients, also to advance medical therapeutics, and that really largely happens. So just get involved.
I have to say that if you look at advanced medical research, a lot of the knowledge without physics scientists, PhDs, and physicians are known a lot more. Well, the basic scientists have more difficult between basic science and clinical science is really important in really determining the conclusion. Most of the things that we do originated in some basic science research projects somewhere. They get to find it and get it into nuance. Clinical practice and something nuance knowledgeable about those. And it's our responsibility in medicine to be enough time to do direct research And I cannot overemphasize what Dr. Dawkins is saying. Get back yourself a mentor is mental. Even you have to take extra year training. That's what I did last year.
Just to follow up on that too, we're actually gonna have a whole session devoted to finding the right research mentor. So please pay attention and we'll give you a heads up.
Well, that was my question, so I'll ask it or see what other things for, like, on finding a mentor, so. Well, I was just gonna ask, like, on finding a mentor, but I'll wait till another session, and we'll go through it with it. And we'll get rid of all.
As you guys are working through your practice and you come up with, I would assume you would have both clinical and translational questions come up, and there's so many things that are unanswered and also things that could be improved on. But how do you kind of network, like working with the PhDs to kind of answer those unanswered questions that we become curious about, and kind of collaborate with them to produce a clinical outcome? Kind of what does that look like? What is your relationship with them like? And how do you kind of network that?
If you're the chair, you just tell them to get to work.
One of the things that I see is that oftentimes there's a disconnect. People that are doing research in the laboratory, people that are taking care of patients. I'll just give you an example. I was in clinic this morning. I'm a nephrologist, and I was working. And we have a world-class PhD scientist who does laboratory research and has hundreds of publications in the highest grants. And I asked the fellow if he knew who that was. He didn't even know his name. They're in the same division. So, I think one of the things that we have to be in a dialogue with these people. So we have research conferences. Some general researchers go. And we have clinical conferences. And clinicians go to those. It's important for the laboratory people to go to the research class to understand the kinds of questions that they're asking. And I have a lot of publications that are basic science publications. A lot of times, if you ask me to actually do the experiments that are published in those papers, I would have no idea those experiments. But I understand, what the techniques are in a sort of conceptual way. I understand how they can be used to answer certain questions. I couldn't do it. I wouldn't know what test tube to pick. But I go to a number of these conferences. I understand what questions can be answered, what methods. And we have a conversation. They talk about what they find, and I talk about where I think that's a big part of it, is just being engaged.
Also, I think it's incumbent on you to find the right person by calling for chemistry, biomedical engineering, and others, who has that interest. If you can talk, I think this is important too.
One of the things I've heard from the engineers is that, well, we can make anything, but we don't know what to make. So tell us what you need, and we'll make it for you. So it's almost at that level. So all you have to do is think of something. Could you make this? And maybe they can. But those conversations don't happen often.
Maybe the best research project is between collaboration between basic science and clinical science. Unfortunately, as the practice of medicine become more laborious and more pressurized, should have very little time to look for the basic scientists to collaborate with, and or to do research, but you're gonna have to make the time. I mean, one of the advantages of working at in this medical school here is that the community is small enough that you could communicate with the primary. You can go and find whoever is interested that you have to take. In a busy schedule, you have to show that and you could discuss things because you know that we're talking about non-answerable or non-searchable. PhDs have also taken action that they don't know that it's not. Yeah. And I think should that could be answerable clinically. So, but that commitment to be that.
Yeah, I think we may need to wrap up, but I just want to put a plug in for, a lot of these questions, I think one of the answers is, obviously those questions that you have, Dr. Dorkin, Dr. Sally, and Dr. Kahala have been hearing for a long time, which is why we really developed this program. So it's not all going to get answered, obviously, in this one workshop, but we've got workshops planned so that you can sort of get that. This is the knowledge that you're not going to get in, sitting in class, et cetera. And then other opportunities, I definitely want to put a plug in for the symposium tomorrow. Again, Dr. Dorkin thought, to answer that specific question, unless people are bumping into each other and seeing what they're doing, then, no one's gonna know to, oh, I didn't know that. So it's where when we did it for the first year, Steve and I we thought we'll get 12 of the nicest posters that you'd ever want to meet. And there was over 100. This year, there's 160 posters, and we're going, we had no idea that all these people are going. And so, so there'll be posters, et cetera. There's obviously the et cetera, but it's a great opportunity, especially as medical students. I know most of you are first and second year, or you're some third, but where you can go and say, oh, I didn't know so-and-so was, they can tell me about Dr. So-and-so who they did work with, and hey, they're in N4, they're going to be graduating, but this project might need, some people to work on it. That's a great way to
Yeah, also at the poster session tomorrow, all the abstracts are published in the book that you can pick up and take with you. So if you don't get around to see all 160 posters, pick up the book, and then you can lead through it. There's submissions from every single division in the Department of Medicine, so there's people working on a lot of different questions. And that's one possible way to identify if you're, GI or critical care or rheumatology. There'll be names in there, people that you can try to connect with.
So I would maybe take one last question and then my question. Oh, sure. Oh,
In the hotel.
Yeah, the
The
post
new hotel.
Yeah. So
The old hotel, that's the new hotel.
yeah, it used to be the Renaissance style, like Woodlands, place or something like that.
There's no Woodlands.
There's no Woodlands. We cut down the Woodlands to make a hotel, but there is a hotel there. So it's right as you see that the hotel used to be a Radisson, but again, the side.
Everything's in the hotel, so the plenary address and the session after is there, and there's also refreshments post session, so you can get a cup of wine and have a hors d'oeuvre.
So again, if you're just, if you go out of the health education building, if you look to the right, you'll see the Rupert Health Center, but you'll see the big lobby down to the bottom. So look for all the people in white.
Give a hand to our distinguished guests.
Yeah, thank you, Greg. So the next workshop, what we have will be in October, end of October. Look for the announcements for that. We'll essentially do this similar format, but on the other side, getting medical students who have been in your position who are doing research and their experiences. All right, thank you very much.